Okay. Okay, so I'm seeing there's a Dutch word on top, but let's. What I was asked to do is to give a general outline of what is GIST, how it is treated, and what are the current developments. So this is really also a presentation for the few of you that that are new in the field of GIST, maybe new patients or not. But and I realize that some parts of it, probably many parts of it, will come back during the next days in more detail, more depth. Please, can I have the next slide?
Mickey, can you help me? I don't know it. Oh, now I got it. Okay.
Yeah. Okay.
I got it. Yeah.
Thanks.
Sure.
Thanks. So it's quite infrequent disease, but there are still about 3,000 to 5,000 new cases in Europe and both in the US. As you will hear later, upon for instance, abductions. So when they open up the body after death and they look at the stomach, GIST occurs much more frequently, maybe up to 30% of patients, but then in a very small form. So there are about 3,000 to 5,000 clinically relevant cases each year new in Europe. There's a similar male to female distribution, and it occurs usually between the 5th and the 7th decade of life, but it may also occur at pediatric age, although very rare, and of course also at older age. It has been only 20 years ago that it has been recognized as a distinct clinical and histopathological entity. Can I have the next slide? So it was originally classified as another type of sarcoma, like a leiomyoma, which is a benign tumor, or leiomyoblastoma, or even a malignant tumor, leiomyosarcoma. That's a soft tissue tumor of the muscle, and it sort of looked the same before we had additional typing of these tumors, and this additional typing consists of immune histochemical markers and molecular markers that I will come back to later. May I have the next slide? So this is immune histochemistry. It's a technique that's been used in the lab. A specific slice of the tumor is taken, and they add antibodies to it, and they attach to certain cells or parts of cells. And this brown discoloration that you can see shows that these cells are present, so it's positive. And the hallmark of GIST has been c-KIT or CD117, and it shows here on the right-hand side. But some of these GIST were negative to c-KIT and were still a GIST. And then about a decade ago, a new marker came into practice. It's called DOG1, and DOG stands for discovered on GIST. So if you combine these markers, usually you can have the right diagnosis. Okay. Next slide, please. Can I have the next, Martin?
Yeah,
Oh, it's difficult still.
Yeah.
Just the button down.
Yeah. Oh.
Yeah.
Now.
Down.
Okay.
Yeah. So this marker on the outer surface of the cell is called the c-KIT or CD117 receptor, and it's a transmembranous receptor. The horizontal lines is a cell membrane. There's an outer part on the upper hand of the slide, and there's an inside of cell part on the lower part of the slide. And this is called the c-KIT receptor. And on the inside of the cell, there is a ATP binding site, which activates the intracellular signal transduction, we call that, that regulates the nucleus of the cell. And please go to the next slide. And this c-KIT is present on many normal cells. For instance, cells that are involved in hematopoiesis, which means the production of blood cells in the bone marrow, or in the melanogenesis, so which is the production of melanocytes. It's for the nice color in the summer. Or the gametogenesis, which is the production of fertility cells in the testes, for instance, and also the interstitial cells of Cajal, which are the pacemaker cells of the wall of the gastrointestinal tract. So these cells do the peristalsis and the contractions that you need for the food to pass in the right direction. And this activation of KIT plays then an important role in all the processes that are involved in cell growth and cell duplication. May I have the next slide? Thank you. So here you can see on the left-hand side, you can see a non-aggressive phenotype. So by just looking at it, it doesn't look very that many cell divisions. And on the right side, you see more mixed morphology. And already, without counting the cell divisions, dividing cells, you can already see that this is more a wild tumor or an aggressive tumor in that sense. May I have the next slide? So these GISTs can occur anywhere in the gastrointestinal tract. So they can mostly occur in the stomach. The second place where they occur is in the small intestine, from duodenum onwards, beginning of small intestine onwards. But they can also occur in the colon, esophagus, or even in the rectum. So they can occur anywhere. Okay, thanks. So the clinical presentation is of course related to the place where they occur. This could be vague gastrointestinal pain or discomfort, or if you are lucky, there could be a bleeding that is a presenting sign, so you know that you have a tumor. But it could also be more general complaints like anorexia, weight loss, nausea, anemia, or other complaints. But in many cases, these GISTs are found by CT scan or sonography echo done for other reasons. I have the next slide. So on endoscopy, this is how it looks like. So when you put a tube in your mouth and the doctor looks whether there is any origin from your complaints, usually a GIST looks like this. It's like a ball that, and I think on the right hand corner, that's the most frequent site you can see, because it's under the mucosa, it's under the lining of the intestine. So usually you cannot see it easily, but you can see some mass that is under the mucosa of the stomach. So if it's small, it might be missed by routine endoscopy. May I have the next slide? Surgery, I'm not a surgeon, but in the stomach, a GIST can just be resected if it's small enough by a wedge resection, as you can see on the left side. So in the beginning, gastrointestinal surgeons were doing surgeries as extensive as a stomach cancer, with extensive lymph node dissection and maybe extensive stomach resections. But really, it's important from the beginning that, and nowadays this mistake is, at least in our country, never been made again, but be aware that if you have a resectable GIST, you only need a wedge resection in the stomach. But if you have a GIST on a difficult location on the right hand side, For instance, in the duodenum near the bile ducts, you might need a much bigger resection. This is an example of a Bilrock-2 resection, but even a Whipple resection, big resections are sometimes needed, and I'll come back to that later. That's why one of the reasons why you want this gist to be smaller before you operate. You have the next slide. So these are some factors that show us what is the what are risk factors, what make the risk higher. So if the tumor is larger than 5 centimeters, if there are more than 5 mitotic counts, so dividing cells per 50 high power fields, which is the one power field is what the pathologist looks at under the microscope, or when it is in another location than stomach, that these are important risk factors that increase the risk of the gist coming back, either in usually in peritoneum or liver. Next. So there are different risk schemes, and you can find them on the internet. This is one of them. For instance, it shows you that you can get a certain number of points, and that reflects the probability of the 2 years relapse-free survival or the 5-year relapse-free survival. In the next slide, is even more clear. May I have the next slide? Yes, this is a heat nomogram, and depending on the color, the darker the color, the higher the risk that the tumor comes back. So from the left side, you can already see that a ruptured tumor has a high chance of recurrence, and that's certainly one of the additional risk factors. Okay, let's go to the next slide. So what happened before imatinib? So more than 2 years ago, surgery was the primary treatment. 5-year survival was between 50 and 65%. If incomplete resection or metastatic at presentation, the median survival was less than 1 year. So it was a disease that we could not treat very well. So up to 9 to 12 months. May I have the next slide? Because often they didn't know what it was, or they thought it was a leiomyosarcoma, they prescribed chemotherapy or other treatments, and there was a very limited response rate, and there was certainly no survival advantage. It has always been said that GISTs are not sensitive to radiotherapy with a limited response rate, but I have to say, and I should update this slide, that now there are new data coming out, certainly for a bleeding GIST that you cannot operate, or for instance a GIST metastasis in a bone that gives a lot of pain, you can certainly consider radiotherapy. Next slide. So coming back to the molecular pathology, the mutations that we were having in the poll and we were talking about earlier, there are different oncogenic mutations seen in GIST. These are the most frequent ones in an order downwards almost, and it's important to know what mutation you have, and to estimate the chances of different medications, how they would work, but also to predict the clinical behavior of the tumor. May I have the next slide? So again, back to this transmembranous receptor, you can see that the different mutations are localized at different places in the receptor. And again, you see the stem cell factor binding on the outer side of the cell, but indeed for GIST, it's not needed to activate this receptor. May I have the next slide? Here you can see on the left panel, you can see the GIST, the KIT receptor, and all the intracellular signal transduction proteins, we call them, and they signal to each other, and finally they give a signal to the nucleus of the cell to be activated. So on the right hand panel you can see a gray spot on the inside of the cell, and that's where the medication for GIST works. So it blocks the activation of the intracellular signal transduction, and it blocks the process of growth and dividing cells. I hope this is clear, and it certainly will come back later during the next days. May I have the next slide? So it all started with cell work, actually GIST cell lines, and they added imatinib to the cell lines, and the upper curve is a normal cell line, the control, without any medication, and it just keeps growing. And on the three lower ones on the right hand is with the addition of imatinib. So in cell lines, the drug worked very well, and this is a publication from 2001. Then the next, please. The imatinib inhibits a lot of different kinases, and the lower the number, the better it inhibits the kinase. So you can see on the lower left-hand side, KIT. So KIT is already inhibited at a very low imatinib blood level. So this is very, very good. It also inhibits BCR-ABL. And some of you might know that BCR-ABL is involved in the progression and origin of chronic myeloid leukemia. So it is also a very good drug for this disease. May I have the next slide? So this is how the pills looked in the beginning, and I was involved in the early phase trials with this drug, and it was really a wonder to see these patients, how they came in with very, very big tumors in their abdomen, and they had been told that there was no treatment anymore from them, so they literally were called back from home or from their hospice. And I particularly remember a patient that came in by ambulance because she couldn't walk anymore, she couldn't swallow pills anymore, and we put a nasogastric tube in, and we put the pills in, and there were really quick responses. So it was really a miracle breakthrough for the treatment of GIST in the early beginning. May I have the next slide? So this was actually the very first patient. It was a patient from Dr. Joensuu from Helsinki, and he treated the very first patient. This is the PET scan. On the left-hand side, you see all the metastatic lesions, and on the right-hand side, you see after only 4 weeks of treatment that most of these lesions were not active anymore and even got smaller. So this was really the start of all this development. I have the next slide. So the EORTC, the European Research Group, started phase 1 study. There was already a recommended dose in CML, 600 milligrams, but we were interested, as this was a different disease, how far we could push the dose, and what we should use to go in further studies. So 1000 milligram seemed to be a little high dose, and we have to realize these were very ill patients when we started, and the daily dose of 800 milligram was seen as a maximum for these patients. Next slide. This is an example of a CT scan with one of these patients with a very big tumor in the lower pelvic area on the left-hand side, and you can see this is all cleared on the right-hand side and is filled again with the intestines. So I can imagine the complaints were a lot less. Okay. Here you can see a combination of PET and CT. On the left-hand side, you see all these peritoneal implants, even in the scar tissue near the navel, subcutaneously, but also in the abdomen. And on the right-hand side, you see very, very good response. So then we go to the next slide. Then the phase 2 studies started. There was in the US Finnish study. They started with 400 milligrams, and upon progression, they went to 600 milligrams. May I have the next slide? This is a phase 2 study, and there were 54% of patients on the initial report that had more than 30% reduction in tumor size, and many others had a small decrease or stabilization. And these responses were durable for many years, we know now. Only 14% of patients had initially progressive disease, and some of these patients were patients that did not have GIST upon central revision. Next slide, please. So it is the conclusion was it was a safe treatment. It was very well tolerated. There were less bone marrow toxicity, and I think it was a good addition to the treatment of GIST. May I have the next slide? So then there were two parallel phase 3 trials, and phase 3 trials are registration trials. And normally you do a new treatment versus the old treatment, but there was no old treatment for GIST because nothing worked. So what they did, and I think this is a very good, these two trials are very good. They looked at 400 milligram once daily, and then they compared that to 800 milligrams. And the patient that had progressed on 400 milligram once daily could go to 800 milligram. May I go to the next slide? So there was really a dose increase question in this trial. May I have the next slide? The accrual was really rapid because there were many patients waiting for active treatment. Normally you do these predictions and you can see that in a few months the whole trial was filled up, which was very good to see. Next slide, please. And here you can see the progression-free survival. You can see the drug worked more than 2 years, and we have still to keep in mind these were patients with very extensive disease, much more than we see nowadays in patients that start on imatinib. So my impression is that the duration of therapy now is longer than in the early days. But what you can also see from this slide, that the starting dose 400 versus 800 didn't matter too much. May I go to the next slide? And what you also could see that if you increase the dose after progression on 400 milligrams, you still had, well, 2.5 months of benefit. When combining these two trials, we found out that patients with exon 9 mutations in their tumors had a longer progression-free survival when they were initially treated with 800 milligrams. May I go to the next slide? Yes. And also this shows that patients with exon 11 mutations had the largest chance for a partial response. And interesting to see that the PDGFR alpha mutations, there was a big difference in response rate, and probably the D840V mutations, come back to that later, were the ones not responding, and the other PDGFR mutations might have been quite some responders in that group. Let's go to the next slide. So this is one of my hobbies, or the hobbies in the Netherlands. This is actually the only one of the few papers that shows there's a relationship between imatinib blood plasma level and the efficacy of imatinib treatment in metastatic GIST patients. And if you are in the lowest quartile, so on the left-hand panel, on the left side of the left-hand panel, below 1100 nanogram per milliliter, you have a shorter progression-free survival. And currently, this is still investigational, but all patients treated at reference centers in the Netherlands have their blood levels being tested. And if it's below 1100, these levels, the dosing is increased. Let's go to the next slide. Then for patients that were progressive on imatinib, sunitinib came into place, as originally called SU11248. Sunitinib does almost the same as imatinib, but also it works a little bit broader and inhibits the angiogenesis, so the new blood vessels by inhibiting VEGFR. Okay, and this is then the results of the phase 2 study. It shows that after the 34 weeks, about half of the patients progressed. So the other way around, it worked a median for 34 weeks, which is a nice addition to the current treatment at that time with imatinib. Next slide, please. So then a randomized study was done, a registration study. So sunitinib was compared to placebo because there was no second-line treatment, and there was crossover upon progression. So each and every patient had access to sunitinib, even when this patient started on placebo. I think that's very fair to patients. It makes it a little bit more difficult for the regulators because you tend to lose the overall survival benefit. But as a doctor, the benefit for the patient is more important to me. So it was a quite large study, 357 patients. Let's go to the next slide. And here you can see that there was a more than, so there was 4.5 months, 4.8 months benefit in progression-free survival, so almost 5 months. So that is worthwhile, and the drug is tolerated quite good if you dose it in experienced hands. Okay. The partial response rate was low, so there were few patients that had more than 30% response. On the other hand, the stable disease rate was much higher, and it's important to keep the patients alive, but it's not really an enormous shrinker of the tumor. But when you're in an advanced stage of disease, adding half a year to life is already very important. Next slide, please. Then the third drug came onto the market, Regorafenib. It's also a KIT, PDGFR, and VEGF inhibitor. Has a little bit different profile in the kinome tree, as you can see on the left side. But there was still a chance that it would work. So again, a phase 3 study was done in the next slide. And these were patients progressing after imatinib and sunitinib, and they were treated with best supportive care or with regorafenib or best supportive care plus placebo. And again, after progression, there was an opportunity to go to crossover. Next slide, please. And here also you can see that still in the third line, almost 3 months, 4 months benefit was seen. So that was a little bit of a surprise. That's quite a good benefit for a third line patient, and we were really happy to see that. And this adds another 4 months on average to the life of patients, and this is a median, and sometimes patients respond much longer to the drug. Okay. It does show some shrinking. This is a waterfall plot. On the right side, you can see the decrease from baseline, and there were quite some patients that had a decrease in size of the tumor, and usually this goes together with a decrease in symptoms. Next slide. Okay, then recently on the market came avapritinib, formerly called Blue. And this drug is in a niche indication for the PDGFR D842V mutant GIST. It's a very rare situation, but these tumors, if they progress, usually the regular drugs like imatinib, sunitinib, and regorafenib do not work, or if they work, very shortly. And this is a really impressive waterfall plot because you can see that each and every except one patient had a good benefit of the drug. And this is very important, and the company has to be congratulated for putting so much effort in such a rare disease indication. And I'm very happy that these patients now have access to a good drug. For the general population on the right-hand side, the effect was less pronounced, and the phase 3 study trying to register the drug for the general GIST population was not enough positive to fulfill criteria for registration. Next slide. Repretinib is also a new kid on the block. This is a study in second, third, and fourth line. You can see independent of line, there's activity. The side effect profile is probably more similar to imatinib than to regorafenib and sunitinib. And you can see here it has activity. Please go to the next slide. And based on that, a randomized study was done in fourth line, so after standard therapy, and the median progression-free survival was 6.3 months versus 1 month. So another 5.3 months is on average added to the progression-free survival of the metastatic GIST patient. So this is really a new breakthrough, and I'm really happy that this was a positive trial and has led to registration. Okay, so my conclusion, and the title is in Dutch, GIST since 20 years is much better understood, and based on that there are much better treatments. Avapritinib and repretinib are the new kids on the block, and we're really happy to use them. And it's a rare disease, and I haven't talked about that, but it's very important that these patients are seen in reference centers, so they talk to physicians and nurses that know the disease, can do the correct diagnosis, and can handle the side effects appropriately, and give the opportunity for patients to enter into trials. Okay, this was all. Thank you.